Hormone Replacement Therapy Part 2, Prescribing. Presentation by Laura, Tiffany, Gina, and Anisha.
There are many different routes for hormone replacement therapy. The differences between them are whether they contain just estrogen, just progesterone, or a combination of the two, as well as if they have systemic or local effects. The oral tablets can come in just estrogen, just progesterone, or a combination. The oral estrogen would include an estradiol tablet or conjugated estrogen. Transdermal can come in the estrogen patch, which is applied once a week or twice a week, depending on the brand and the dosage. There's the estrogen gel, which is dispensed in a metered pump and applied typically on the arm. There's also either the arm or thigh, actually. The progesterone gel is similar to that. There's the estrogen spray, which is an estradiol transdermal spray sprayed 1 to 3 sprays once a day applied to the forearm. There's the estrogen emulsion and then a combination patch. For vaginal options, there's a estrogen vaginal cream that comes in an applicator. There's the tablets, the soft gels, the ring, and then progesterone gel that also comes in an applicator. Then there's the 2 IUDs that are progesterone only. Since there's so many different routes for the hormone replacement therapy, depending on why they are taking the therapy would help determine a route that would work for them and also how they want it to fit into their daily lifestyle.
Formulations for various issues. Estrogen. This is used for women who have had a hysterectomy, and there are 2 preparations. The first is systemic, which comes in oral tablets, transdermal patches, creams, sprays, and gels. The second is local, which is creams, tablets, rings. Estrogen progesterone therapy is for women who still have an intact uterus, and you'll just take a pill on a daily basis. Progestins. This is to protect the uterus against endometrial hyperplasia, and the forms that it comes in are listed below. Progesterone creams. This is for endometrial protection to avoid systemic progesterone effects, and it helps improve vasomotor symptoms. Estrogen baxadoxaphene therapy is for women who have an intact uterus, and the baxadoxaphene protects against endometrial hypertrophy and malignancy. This is a pill you'll take daily and continuously as well. The last is estrogen-androgen therapy. This is for the sexual effects of menopause. It improves the loss of libido, and its side effects are alopecia, acne, deepening of the voice, and hirsutism.
Hormone therapy is considered the most effective therapy for menopausal vasomotor and genitourinary symptoms. There has been much debate on the safety of hormonal therapy and which doses are the most beneficial and effective. As women age, the risks appear to outweigh the benefits of hormone therapy, with the exception of low-dose vaginal estrogen therapies for genitourinary symptoms of menopause. Therefore, it is recommended that hormone therapy used by women who are younger than 60 or still within 10 years of the onset of menopause, and only in women who have no other contraindications such as a history of breast cancer. The risk of breast cancer has been shown to increase after 3 to 5 years of estrogen with progesterone therapy. Women who have a uterus should take progesterone with estrogen to keep the lining of the uterus from proliferating too much, which could lead to cancer. Women who have had a hysterectomy can take estrogen alone. Whenever initiating hormone therapy, the goal should always be to use the lowest effective dose. Oral doses of estrogen include the conjugated equine hormone or 17-beta estradiol, and it is recommended by ACOG and the North American Menopause Society that initiating estrogen therapy either alone or in combination with progesterone, should be started at doses of 0.3 milligrams for conjugated equine hormone or 0.25 to 0.5 milligrams of 17-beta estradiol. There are various progesterone formulations and doses that can be used in conjunction with estrogen. If symptoms do not resolve, doses can be increased or different combinations can be tried. The duration of treatment should be individualized and guided by an ongoing assessment of risks versus benefits. The risks of breast cancer, coronary artery disease, venous thromboembolism, and stroke appear to increase with longer duration of use or initiation of use after the age of 60.
Hi, this is Tiffany talking about bioidentical hormones. So these are somewhat controversial. The term bioidentical is a marketing term, and it's used to imply a natural plant-based hormone that mimics human hormones, because the theory is it sounds safer and more natural. And while it's true that the estrogen-like compounds are extracted from plants, they are lab engineered, like most medications. There's concern that these custom compounded creams or the suppositories or the pellets that are used are not FDA regulated, and so that they may not contain accurate amounts of the hormone ingredients may vary in potency. So there are both FDA approved and compounded bioidentical hormone therapies. So we're going to get into that in the next two slides, the two different perspectives. FDA-approved bioidentical hormones include estradiol, estrone, and micronized progesterone. Those are regulated and monitored for purity and efficacy. Compounded bioidenticals may combine 17-beta estradiol, estrone, estriol, also DHA, testosterone, and progesterone in combinations administered via subdermal implants, creams, pellets, troches, which are dissolvable under the tongue tablets. And those may be over or under dosed if they're not mixed correctly. And there's not enough data about the bioavailability of the different methods of delivery. If symptom control is the goal, there's no need to assess hormone levels in serum, urine, or saliva. And a lot of practitioners use saliva tests to customize hormone doses. There's not data to back up that this is accurate. These products don't have labeling or inserts with standard warnings required of other estrogen products. And there's concern that there's the last 10 or 15 years or so, endometrial cancer has increased, and there's also been an uptick in the compounded bioidenticals. There's no causation that's been proven, but that's just a concern. According to compounding pharmacists, the statement that bioidenticals are not regulated is inaccurate. They have to comply with federal and state laws, including the Drug Quality and Security Act, which the FDA has powers to regulate compounding pharmacies. They've established this requirement of compliance with the good manufacturing practice, and that has allowed for improved testing of the process, purity, potency, and quality testing, and sterility protocols. So they have to adhere to all of those things. Also, women's testosterone levels drop before and after menopause, and there's growing evidence that individualized doses of testosterone can increase libido, assist with prevention of osteoporosis and cardiovascular disease, and decrease invasive breast cancer. So there's just more research coming out about that. Even though there aren't recommendations for testosterone, it's off-label use for women. According to ACOG, there is greater dosage flexibility, availability of low-dose preparations, and potential lower cost with bioidenticals. After starting a patient on hormone replacement therapy, follow up with them in 3 to 4 weeks to see if they're still experiencing vasomotor symptoms. You can titrate the dose as needed, and then once you find the maintenance that works well for them, they can continue that for several years and then start tapering in 3 to 5 years. 5 years is the standard length of treatment, but it can go past that if benefits outweigh the risk. Routine mammograms and breast exams are recommended, and ask your patient to notify you of any abnormal vaginal bleeding after the first 6 months of treatment or any signs of thromboembolism.